looks like, at least I'm grateful to see that some of you have come back, and maybe if we're lucky, more will flow in nice and quietly for this panel session. So we still got two more interesting speakers for you, and the first one is George Dafoulas. George is a doctor and also a PhD student, a consultant, and he is one of those, again, with many, many titles and areas of work, of which you can read more in the program. George will be talking about the Greek pilot in Renewing Health, about applying evidence-based medicine in telehealth. Welcome, George.
Thanks, Janne, and thanks to the conference organizers for the kind invitation and the opportunity to present our outcomes. So I will present the outcomes from a coalition of partners in central Greece. It's the Municipality of Trikala and the Regional Health Authority of Thessaly. So the basic components of my presentation is an overview of the current status and evidence-based medicine data in telehealth, the Renewing Health outcomes from central Greece, and the United4Health vision and what our objective is there. So I will not not contribute something extra with this slide. You all know, and especially in a conference like this, all the audience is familiar about what is at stake today, and is the sustainability of our healthcare systems, and it is already discussed already from the morning, and it is so obvious, and it became a policy, and you can see the digital agenda for 2020 of Europe that wants to make telehealth an everyday clinical practice on larger scale. So, while we discuss all this topic for many years now, and in many countries, telehealth has not taken hold, has not become an established routine care. And there are many challenges already identified, and I will talk a lot, my presentation focus mostly on the clinical. And telehealth is another new type of, with technology, a new type of service sometimes, or in addition to the service, but this is nothing new in medicine. Doctors are familiar with some new technologies entering their daily practice, so it's not a big deal that something new enters. So, but the problem is that telehealth has to prove that it works. And this is where modern medicine, where evidence-based medicine comes from, evidence-based medical practice comes from. And you can see it has three pillars. One is the experience of the doctor, it's the evidence from the literature, and the patient's values, the health system values, and all these make the medical decision if I will follow a method, if I will adopt telehealth or not. So how the evidence comes from trials that gradually become reviews, and then they become guidelines, and they become part of the medical textbooks. Okay. So you can see, for example, here the guidelines for treatment of chronic heart failure. And they have discussed the remote monitoring with personal health systems and the structural telephone support. But they conclude that there is not enough evidence to recommend to all the cardiologists all over Europe to follow that in everyday clinical practice. So we have a problem here. If the doctor will follow it or not, the medical guidelines do not recommend it. They cannot support it, they say. And there have been some efforts. For example, American Telemedicine Association have tried to establish some standards and some guidelines, but there is not enough evidence there. And this is what Renewing Health, as Panos already explained, is trying to, with the support from the European Commission, to provide this evidence. And you can see, for example, in diabetes type 2, where we have a trial in Thessaly, the current evidence, for example, shows that there is a trend, that there is a promise that telehealth can work. The more favors treatment, if you go on the right, then it means that this works better than the control. But if you see that the number of the trials here in this review, they involve a very little number of patients. So there is not enough power to support this conclusion. And so, for example, in a Renewing Health trial in diabetes type 2 monitoring in 3 regions, we succeeded to include hundreds of patients, and in order to increase that value. And I will present the primary outcomes from Thessaly, which is the quality of life measured with SF36, which is a validated tool to measure that. And glycated hemoglobin, which measures how effective was the diabetes treatment the past 3 months. It's measured. And the basic of our system is you're familiar with most of these technologies. There is a personal health system that transfers the data to the mobile phone and then to a server, and then doctor can access it, this data from the patient. From our trial, we both in control group, which was the standard care, and the intervention group, they proved to be effective. They managed to decrease the level of glycated hemoglobin. So this is good. It means that the treatment works in both standard care and telehealth. But you can see that telehealth succeeded better. And when we analyze that, if the comparison means statistically, that makes if it works statistically, if it's enough power to support it, the statistics show that the intervention really, the telehealth service really performs better. And both in the quality of life also, measured with SF36, it has 2 components, the physical component scale and the mental component scale. So both standard care and intervention care with telehealth, they improve the score, but they don't improve in control group, you can see that the score was not better after the 1 year of treatment. While in the intervention, there was a small improvement. And also in the mental component scale, the same outcome of the SF36. And when we analyzed the difference, we concluded that this is statistical significant difference. So the preliminary results from the United4Health trial in Thessaly show that telehealth is more effective than standard care, and that standard care sometimes focus a lot on the health outcome, which is the glycated hemoglobin, but doesn't pay attention a lot, doesn't address the quality of life of the patients. So we have to deal with this issue also. And also in COPD, the review of the literature, there is some promises from the literature, there is some signs that telehealth can perform better, but again, the number of the trials, they involve very few patients, so there is not enough statistical power to prove this outcome. And so in the United4Health trial, in 3 pilot sites, we managed to include a big number of patients. And I will present the quality of life, which is a secondary outcome measures from Thessaly. And both the control and the intervention group perform, they tend to improve the quality of life of the patients, but statistically this cannot be supported in the SF36 scores. In the mental component scale of the SF36 also, we have an improvement, but it's not statistically significant. And when we examined if the difference is statistically significant, again, we couldn't prove that the outcome was statistically significant enough to support that there is a better outcome after the intervention or the standard care. So, but when we watched on the workflow of the patients, we divided them in 2 groups, as you understand, the intervention and the control group. We watched that in the control group, a lot of them don't go to their appointment. So this means that intervention, the telehealth, managed to provide to these patients the service, while the standard care fails to provide this service to the COPD patients. So the outcome is that is equally effective with the standard care. We cannot say that is a better as far as quality of life is involved, but it can provide better access of the patients to the medical health care. And while, as Panos explained already, I will not stay a lot here. Randomized controlled trials provide the evidence for the medical professionals, but they are a small greenhouse. So they are very restrictive, and we have to find a way how to generalize the outcomes. And that's why we use observational studies. And this is where United4Health will do also in Thessaly. we will try to generalize the outcomes and identify which groups of the patients need this, this intervention in order to become more useful to these patients. And these are the funding where it comes from, our funders. It's the European Commission, the Ministry of Health, and the Prefecture of Thessaly, and the Municipality of Trikala. And the partners is the Regional Health Authority and the municipal agencies that support the trial. And that's all, and thank you for your attention.
Do we have any questions for George from the audience? Or? I mean, there's plenty of time. George, he speaks so fast that it was all... Yes, Mark. Oh, Mark first, and then we can go to Marco afterwards.
With the discussion that we had on the contradiction between expectations or between the contradiction that we identified just after the break, you will apply, you will use in, or you will implement in under United4Health an intervention which will be very similar, identical, or which will be slightly different or very different from what was implemented in Renewing Health, meaning what are in the design of the system, in the design of the intervention, what are, if any, the lessons learned? And I'm asking this question because I would expect, but who am I to provide an answer to the discussion that we had yesterday, earlier? I would expect that the question of the contradiction between the expectation of the patient and what the health professionals, the clinicians can deliver, could be solved through a redesign or refinement of the system by creating the necessary feedback mechanism, either automatic feedback, at least a minimum automatic feedback, but also some other feedback by nurses or by social workers or by any other team. Meaning, there is always a possibility to refine or to make an evolution of the design of the intervention. What will be the case, so now to make it short, what will be the situation now in Thessaly? Thank you.
Thanks for the question, and this is another part of the study we made. We performed an organizational aspects qualitative evaluation study, and we found out that diabetes, with the present status of the healthcare structure in Greece, is the one that can be partly reimbursed and can match with the workflow existing already. So that's why we selected for United4Health diabetes telehealth. While COPD and tele-monitoring of chronic heart failure are very difficult to be adapted to the existing workflow and find the reimbursement within the present health system. And so, based on the outcomes of our organizational study, we decided to follow with, to go on with diabetes service only.
Thank you. Yeah, Marco.
Okay. Marco. It was very interesting, the slide that you showed about the number of people lost in the control group compared to the intervention group. Could we speak about the compliance? Because in reality, those people did not do the control consultation with medical doctor. If we call it compliance, that is an extremely important result, because in reality, we do not, I mean, the clinical outcome is not extremely relevant, but the compliance is totally relevant.
Yes, that was the major outcome, I think, and the conclusion we made. In the COPD patients, you can imagine that after an exacerbation, their health is deteriorated, their status of health, and they already, because of their disease, they stay a lot in their house. They have oxygen supply usually for many hours. They cannot move easily. So for them to access the doctor on their checkups, because according to the guidelines, they have to go after 1 month and all this type. The health system doesn't provide to them the service and the access for all this monitoring. And for them, especially when they live away from the hospital or they don't have someone to support them, it's very difficult to have the follow-up, the proper follow-up. While telehealth allows that to the patients. But the control was just the standard care, so it was already the way it works. We didn't change anything in the standard care. So
yeah, but it Exactly my point. They didn't comply with the standard care because they were supposed to be seen by medical doctor every so many weeks or every so many months, but they did not, while the people in the intervention group quite clearly, because they were tele-monitored, they were compliant with the protocol. So, I mean, it's why I'm insisting that should be presented under the heading compliance, not only under the heading of access. The better access improves the compliance. What we want from the patients is compliance at the end, don't we?
Well, the reasons for compliance sometimes is access, I guess so, yeah.
Exactly. It's just marketing, nothing else.
Do you have any other questions? Or if not, I've got just a final one. I mean, the overall theme of this conference is the co-creating patients. Now, I know you weren't asked to present anything on that, but it might be worth knowing, how do you see patients taking part in actually the further sort of development and design of telehealth services? So if you've already begun a journey, you can say, how will you take them along for the ride in the future?
From our patient satisfaction survey, we use the same tool as Igne told you already. They see it as something extra to their standard healthcare as telehealth. They don't see that it can replace it completely, the standard care, and they don't seem to worry a lot about privacy. Things that we thought that the patient satisfaction questionnaire will raise, they were not seemed very worried about this, at least our trial. This is our outcomes from the patient satisfaction survey, yeah.
Thank you. Well, thank you, George.
Thank you.
And from the organizer, there's a little present for you as
Thank
well. Thank you.